Hi, this is Dr. Gogas, Editor-in-Chief of USC Journal, and today I have the pleasure to have two very special guests with me. Dr. James Blankenship from the University of New Mexico and Dr. Riangwiwat from Geisinger Medical Center in Pennsylvania. They both are with us today because they submitted an excellent paper to our journal that has to do with the radial access and how to troubleshoot complex anatomies during our operation. Dr. Blankenship, Dr. Riangwiwat, thank you so much for being with us today.
Hi, good morning. Our paper is about radial artery complications, but first of all, I just would like to talk a little bit about radial access. We are in the radial first access era, and the reason is that the radial artery access has been associated with the lower vascular complications and lower breathing complications, earlier ambulations, better post-procedural comfort, and better cost effectiveness. The serious complications that associated with transradial access that really require surgical interventions or percutaneous intervention is pretty low. It's reported at 0.3%. And these serious complications actually can be decreased by prompt recognition of the complications and correct management. Now, to get a radial access, there are two main techniques. It's the antria or single wall technique or double wall technique. For the single wall or antria wall puncture, it is adopted directly from femoral access. And the reason is that in the femoral access, we try to avoid the posterior wall puncture, which can act as a source of bleeding. But however, this technique can be a little difficult for the small artery. Lucky for the radial list people, because the posterior wall puncture bleeding is not as much of a concern for the small artery like the radial artery. So for the radial artery, we can do the double wall puncture, which means go through and through, pull the needle back until you go back to the lumen before you thread the wire into the artery. And this is easier for the artery, the small diameter artery. Now, after getting the access, the next step is putting the sheath in. The sheath for the radial access is a little different from the femoral access. It's supposed to be hydrophilic coated with a tapered tip. Otherwise, it will cause some complications, which we'll mention later on. And the drawback of the radial artery is because it's small. It's only 2 millimeters on average. So we try to use as small a size of the sheath as possible that will allow us to finish the procedures. And there are some equipment that try to facilitate us for that. For example, this cylinder, guide sheath cylinder, is the sheath that has a big internal diameter, but has lower profile so that it can go through the small artery and also can accept the bigger guide catheter. And some type of the artery will be really need to use the small sheath for it. And the sheathlet guide is also another option that we can use when you really need a bigger catheter for the procedures. Now come to our paper, which is about vascular complications of transradial access for cardiac catheterization. The first complication that we'll talk about is the radial artery spasm. This is pretty common. It's the most common cause of transradial access site crossover. And the incidence about 4 to 5%. The risk factors for this radial artery spasm are female, young age, low BMI, small artery, large sheath size, and multiple catheter exchange. These risk factors are actually pretty common risk factors that share among many of radial artery complications. So for prevention and management, the first thing you should do is make sure the patient has adequate pain control and analgesia. Very rare case that we will eventually need a general anesthesia or regional nerve block. We should use a hydrophilic coated long radial sheath. Using of universal catheter like Jackie or Tiger will help reduce the radial spasm just because this less catheter exchange. And the thing that we usually do the most is also antispasmolytic a vasodilator like verapamil, diltiazem, or nitroglycerin. There's no perfect combinations, but there's one systemic review that suggests using a 5 milligram of verapamil with or without nitroglycerin of 100 to 200 micrograms, probably the most effective regimen. And the next complication is the non-coronary artery dissection. And it could be radial artery dissection, or it could be an ascending aortic dissection, as you see in the picture. The risk factors for an ascending aortic dissection is like underlying aortic aneurysm, acute coronary syndrome, or an intervention to the RCA. For the radial access, using an aggressive catheter or guide manipulation can also increase the risk of aortic dissection. And for treatment and prevention, for the patient who have an ascending aortic dissection that is small and is related to RCA intervention, stenting the ostium of the RCA is also a proper management for that as well. Otherwise, if the dissection happens in the radial artery, recognize it during the procedure. It's not a prohibition. You don't have to stop the procedure as long as the Y can pass through the lumen proximally safely. Because during the procedure, the catheter or the sheath will seal off that dissection. And at the end of the procedure, you probably should do another angiogram just to make sure that how is the dissection has to seal off. And if it still has the residual dissections, external compressions can be used, because if it's not managed properly, these dissections can propagate into a forearm big hematoma. And if it gets worse, then it may be heading to a compartment syndrome. The other technique that can be used to prevent the dissections is using a balloon assisted tracking. What it is if you look at the picture A, the laser effect is the mismatch of the size of the Y and the inner diameter of the catheter that leaves the sharp edge on the tip of the catheter, and that sharp edge can cause an injury to the vasculature. Using the balloon assisted tracking means you have the Y, you have an inflated balloon inside the catheter. And that will help to smoother the transitions of the size of the Y to the catheter, and it make advancement or withdrawal of the catheter easier. The next complications is radial artery perforation. The incidence is pretty low, 0.07 to 0.9%, and they share the same common risk factors with other complications. And also the management is pretty much similar to the dissections. You don't have to stop the procedures as long as you can pass the Y proximally safely. And the catheter or the sheath will tamponade it later on. If not, then external compression can be used after. And if it's not getting better, then be aware that you might need a surgical repair and the hematoma evacuation later. And this is the picture of the perforations complications. Picture on the left, you can see the perforations, but the Y was able to pass proximally. So after the procedure, the catheter has sealed off that perforation. Then the next one is hematoma. We're pretty familiar with this complication. The incidence of the hematoma for the transradial access is 1.2 to 2.6%, which is actually about 60% lower than the transfemoral access. The risk factors are multiple artery punctures or inadequate management of the radial artery perforations and misplacement of the compression device. The early recognition of this hematoma is very, very important because early management will prevent the serious complications like compartment syndrome later on. Now, the management for this hematoma is compressions, compressions, and compressions. It's either with manual compressions, add the pressure into that pressure band, or we adjust the compression device. Be aware that if the hematoma gets bigger, you might need a surgical evaluation later on. And the next complications is AV fistula. This is the connection between the artery and the vein, and it's pretty rare. It's only less than 1 in 100, about 1,500. The patient can be asymptomatic, or it can be persistent pain, and you can see a palpable thrill in the artery. And the main risk factors for this is multiple punctures, because radial artery was surrounded by small vein around it. So the treatment and prevention of it is similar to the dissections and perforation. Usually the catheter will tamponade the fistula. If not, then you use an external compression. The indications that surgical repair will be needed is when there is symptomatic atrial seal phenomena or venous congestions of extremities or high output cardiac state. Now the next complication is respiratory pseudoaneurysm. It means that what it is it's a penetrating injury of the artery wall that's causing a pulsatile extraluminal hematoma that still has a communication to the lumen. Usually patients will present with a palpable mass with or without tenderness several days after the procedure. It's not, usually we don't see it immediately. The incidence is low. The risk factor also share the common risk factors, but also cardiac infection and aggressive anticoagulation are the risk factors for this. Prevention and management also similar compressions. But the next step is using an ultrasound guide thrombin injection, knowing that we have a really small target for that pseudoaneurysm as compared to femoral access. There are some indications for surgical excisions of this pseudoaneurysm. For example, pain, diameter more than 3 centimeters, or failure for those above conservative management. And the last complications in the bleeding group is the compartment syndrome. Every complication that we talked about before this one is we don't want it to progress to this compartment syndrome stage. So it is a compression of the nerve, vein, and artery and muscle inside that forearm compartment. The incidence is low, and the risk factors are also the common risk factor. Like if we don't manage the hemostasis good enough earlier, then that will lead to the compartment syndrome. And the one thing I want to mention is the ulnar artery access. If you do use the ulnar artery access, you should try to avoid getting the access too proximal from the wrist, because the more proximal is more difficult to get hemostasis, and because it's more difficult to compress it against the bone. Now the treatment of compartment syndrome, the main thing is prevention, because maintain the high index of suspicious. If there's bleeding complication, manage it early. Don't let it become a compartment syndrome. If it's already happened, then consult the surgeon quickly, because fasciotomy will be needed. Now we're gonna switch here from the group of the bleeding complications to the group of clotting complication instead. The first one is the radial artery occlusion. This is a benign condition because most of the patients will have ulnar artery collaterals that will protect the palmar circulation. And about 2/3 of the patients that have radial artery occlusion will have the spontaneous recanalizations later on anyway. The risk factors, also the common risk factors like the small artery, the radial artery to sheath ratio less than 1, multiple puncture, low anticoagulation dose. Arterial spasms is the risk of radial artery occlusion. So the radial spasm should be treated properly as well. And the prolonged occlusive hemostasis, also the risk of radial artery occlusion as compared, so the prolonged occlusive hemostasis, try to avoid that, but instead use the patent hemostasis. For prevention, as I mentioned earlier, patent hemostasis, give heparin during the cardiac catheterization and use as small sheaths as possible. Lateral ulnar artery compressions can be used both prevention and treatment in acute radial artery occlusion. If it's not quite acute anymore, then the patient will need an anticoagulation. If repeated cardiac catheterization is needed, then consider using a distal radial artery access that will actually kind of help with the recanalizations of the radial artery occlusion. And the last complication of today is the hand ischemia. The incidence is also rare, and the risk factor that is listed here came from all the radial artery cannulations, not only for cardiac catheterizations, and it's usually pretty common risk factor that we know about, like smoke, peripheral arterial disease, Raynaud, and radial artery spasms. Usually the patient will present with kind of dusky appearance in the hand, as you can see in the picture. And most the prevention is a close monitoring. If the patient has hand ischemia, then IV verapamil, IV diltiazem, or heparin. If eventually the surgical is needed, note that radial artery reconstruction with interpositions with cephalic vein overall has a better success than the vein patch angiography. So for our take-home message, because we have been using more and more radial access, we will see more and more complications. I want the cardiologist and the cardiac cath team to be familiar with these vascular complications, because early detection is very important, because if we don't treat it properly, if we don't detect it early enough, this will lead to a worse complication. And if we group the complication into two groups, the hemorrhagic and thrombotic complications. The hemorrhagic complications like perforation, hematoma, AV fistula, or aneurysms, those are mainly treated with compression. On the other hand, the thrombotic complications such as radial artery occlusions or hand ischemia mainly is treated with anticoagulation. And I would like to encourage people to have a preventive strategy and post-procedural monitoring to be implemented in every cardiac catheterization lab.
Well, Dr. Riangwiwat, thank you so much. You gave a great talk based on the paper, and you described very extensively and very precisely the essentials of the radial first approach, but also how to troubleshoot all those complications. And let me switch now to Dr. Blankenship, a very accomplished interventionalist and pioneer in the radial first approach. Dr. Blankenship, in your practice, what is the percentage of the radial first approach as opposed to the safe femoral?
It's about 92% radial, and the most frequent causes of us not being able to radial are, in my present institution, are patients on dialysis with dialysis AV fistulas. And we have many patients who have, for instance, a fistula on one side that no longer works and an active fistula on the other. Although I have on occasion actually gone into a radial artery where there's an old failed fistula and been able to get antegrade access, or I should say retrograde access through that.
And have you adopted also radial first in your STEMI patients?
Yes, we started that at Geisinger Medical Center about 10 years ago. And we have several different operators, and over a series of several years, the individual operators adopted that. So I started it in about 2010, and we actually looked at our door to balloon times, and it was not prolonged. We're able to achieve the same door to balloon times with radial.
Okay, that's great. Congratulations. I read recently a paper from the NCDR registry saying that in the US, we have a radial first approach in the STEMI case or setting about 25%. Is it true?
I haven't seen that data point, but it's believable. I think that operators who are not comfortable with the approach are much happier doing it on an elective case and selected cases, and it's a little higher stakes when it's a STEMI. But our experience has been that once you get a moderate level of expertise, that it's quite feasible to do it for STEMIs on a routine basis. And my own personal experience is, for some reason, it seems easier in the average STEMI patient than it does in the other average elective patient, perhaps because STEMI patients tend to be a little bit younger.
I totally agree. Well, yeah, there was a little bit of delay in the adoption of the Radial First approach in the US as opposed to Europe or the East Asia. But I think now is catching up. The numbers are catching up. Dr. Riangwiwat talked about the short versus the long sheath and the hydrophilic sheaths. Do you think that the short versus the long sheath plays a role to facilitate a better procedure, or is still the same?
So there are some studies that said that when we compare between the long and the short sheath, the long sheath has less radial artery spasm, but honestly, the study is not like consistent across the board. In here, most of the time we use the long sheath, except that when we cannot pass the long sheath in, that's when we use the short. But definitely, if you decided to use a short sheath, then definitely prepare for that cocktail to prevent the radial artery spasm.
Just last night, I submitted the IRB protocol for a randomized controlled trial of short versus long sheaths that I hope Dr. Riangwiwat will be able to participate in at the Geisinger Medical Center, but with the endpoint being the discomfort of actually placing the sheath, with secondary endpoints being safety and efficacy endpoints. But interestingly, that has not been studied in randomized controlled trials between short versus long sheaths.
Sure. Also, when I started practicing the Radial First approach, I was making an incision at the side of the puncture. But then I realized that we don't need a skin incision because, due to the DAVT or the heparin that we're giving, we may facilitate some hematoma. Do you both do the skin incision, or you skip it, you avoid it?
I don't normally.
Right. I think it's a common misconception that you need to make an incision in the skin, but absolutely not true.
Yeah. So you talked about balloon-assisted tracking, the BAT technique, and Dr. Blankenship, you have so much experience. Can you tell us about the balloons that you are using, low profiles balloon, short or long balloons, and if with a BAT you are not successful, what are the criteria to switch from the right to the left radial artery, or then to the safe femoral approach?
We would use about a 2 millimeter balloon. The length doesn't matter as long as you have enough sticking out the end of the catheter to provide a tapered tip around the wire. But a 2 millimeter balloon blown up to 5 to 10 atmospheres usually works quite well. Other strategies are to simply twirl the catheter as it goes up, and that helps you to get around tortuosities in the artery, and that often works without having to use the balloon-assisted tracking technique. I have a low threshold whenever there's an anatomic problem on one side to switch to the left radial, and an interesting point is that the anatomy is not symmetric. Just a week ago, we had a case where there is a radial loop on the right side that I could not get around. So we switched to the left side and took an angiogram of the arteries in the arm, and it was an absolute straight shot right up the radial artery. So it's a misconception that if you can't do it on one side, that the anatomy will be unfavorable on the other. So I have a fairly low threshold.
Wow, that's a great message. Yeah. Now, let's talk about the cocktail. So you mix the verapamil with nitrate. Do you give the heparin in this cocktail, or you give it from the other from another axis, from another vein?
I agree with Dr. Riangwiwat that either way it should be equally efficacious. I do not think there's any advantage to giving heparin through the sheath, although I know that many people do that. But we traditionally have used the peripheral IV approach to giving the heparin.
Okay, that's great. And you talked about perforation. I mean, even if we see a perforation, we can go through with a wire, we still need to continue the operation because the guide catheter, I mean, will tabonate the place that has this perforation. Now, when we're having a large hematoma and Dr. Riangwiwat sent compression, should we inflate the blood pressure cuff above the systolic blood pressure or below? What is the number that you choose?
It should be above systolic blood pressure, just to prevent the further bleeding.
And how long do you keep it?
Usually we don't keep it for so long because it's gonna also prevent the blood to the rest of the arms. We usually just do it for like 10-15 minutes and reassess. And we usually work with with like kind of cap tech, and we kind of keep checking on the patient. The other technique is, apart from the blood pressure cuff, we can also use the bandage. Just kind of go up really, really tight and just go up and then just wait for like 10-15 minutes. Take it down, see if it stops bleeding.
I see. Well, Dr. Blankenship, you are more experienced in so many years in your practice. Have you seen radial artery occlusions?
Sure. Yeah, as Dr. Riangwiwat has said, the incidence is between 2 and 5%. So certainly we do. Most of the time they're asymptomatic, and the main problem with the radial artery occlusion is that it prevents re-access through that same site.
So Dr. Blankenship, as a very experienced operator, Radial First, and a public figure in the United States, give a message to the mid-career interventional cardiologists. What should they do? What should they follow? What should they avoid?
Are you meaning with radial access, or just in life in general?
In general, in our profession, in our subspecialty.
Sure. I think that the first point is that patient care always comes first, really above every other consideration, both personal and professional. So you got to put the patient care number one. And I think that an important message for interventionalists is to recognize that you're part of the team in your cath lab. And in fact, you're the leader of the team. And so it's the responsibility of every interventional cardiologist to take care of their members of the team by helping them advance professionally, by encouraging them to grow in their profession, or even to take on new challenges, and look after the emotional welfare of the team, and to mentor younger cardiologists coming up through the academic ranks. And I think Dr. Riangwiwat is an excellent example of what fellows can achieve at a fairly early stage in their career by finding a mentor and taking every opportunity they can find to advance themselves, both in terms of knowledge and skills and academic productivity.
Yeah, these are great messages. And I would like to close the discussion with Dr. Riangwiwat as a woman in cardiology and a young interventionalist. What advice would you give to women in cardiology who want to become interventionalists?
So I think time management is also very important. Is kind of balance between the work and the life. Balance is important for like us. Also, sometimes being a woman is a little different than being a man when we have to give an order. I still have to kind of improve myself as well, but build up your confidence, be affirmative, and kind of say things when you feel confident that you can do it.
Great. Well, I mean, I loved your presentation. I enjoyed very much your paper. And I would like to thank you both for being here with us today. And dear colleagues, we had a very nice discussion with Dr. Blankenship and Dr. Riangwiwat about radial access. And I would like to thank you for being with us today.